All right, I'm going to get started. So my name again is Christie Thomas. I want to thank Richard and Lynn for asking me to come and join you at this conference. I'm a great admirer of them, and thanks to them that so much advances have been made in this disease, C3G. I wasn't able to join you for dinner yesterday, but I'm sure you had a good time, and there's another good meal we're going to have this evening in their own home. So you have wonderful hospitality here. So I join them in welcoming you to Iowa City. We typically have much better weather than this, but we're not here for the weather anyway. So hopefully you're going to learn a few things. So I am a transplant nephrologist, meaning my primary interest is taking care of patients, usually adults who had a kidney transplant or need a kidney transplant. And my goal today, I have two talks for you. One is on kidney transplant versus dialysis. And the second talk is on how to find a living donor or something to that effect. Again, the title and the objectives were given to me by Richard and Lynn. All right, so here are my objectives. Recognize that long-term dialysis is an option, not just for people with C3G, but for any kidney disease. Understand when transplantation is the right step. Be aware that there are several drug regimens, but Richard specifically wanted me to mention the steroid-free regimen in conventional kidney transplant. So they usually use 3 drugs, and if the steroids are dropped, that will be 2 drugs. And I'm going to talk about some other alternative drugs we had. Carla has already introduced you to a couple of the drugs that we commonly use. I'm going to go over some side effects. Again, Carla has gone over the side effects already with you. There's some additional side effects that I will mention. Again, risk of skin cancer is something that Richard wanted me to mention. And then I'm going to talk to you about how we monitor for recurrence. And recurrence is the idea that the disease that you started out with that affected your native kidneys that led you to get kidney failure can come back in the transplanted kidney. And C3G is one of those that is, if you will, almost notorious for coming back universally after a kidney transplant. But there are a whole host of other conditions that can occur in the transplant kidney after you've been transplanted. And so we need to be monitoring for things that affect the health of that kidney, including the recurrence of C3G. And then I'm going to talk to you a little bit about how we differentiate between meaningful recurrence, that is something that affects the patient clinically, change in urine protein, change in creatinine, decline in kidney function, versus just the appearance of C3 on a kidney biopsy. All right, so when might chronic dialysis be considered? And again, just to put this in context, there are many situations where we may do short-term dialysis in patients who don't have kidney function. So we're talking about dialysis as a long-term option. That's chronic dialysis. It's essentially 2 forms of dialysis. For those of you who haven't actually experienced dialysis yet, there is a form where we take blood out through a fistula or a catheter in the neck, which we call hemodialysis, dialysis via the blood, versus peritoneal dialysis, where we have a catheter in the belly and we use the peritoneal space as the natural dialysis membrane to improve body chemistry and renal flow. So those are the 2 options for chronic dialysis. And if you need to do chronic dialysis, you would want to be thinking about a particular form of chronic dialysis that I'll get to. So when might you want to do chronic dialysis versus consider a transplant? And this is particularly true for the disease C3G. But obviously, you have to wait in line for a kidney transplant unless you've got a living donor lined up who can then can give you their kidney right before you need to start dialysis. Most are not lucky enough to be in that situation and have to wait their turn to get a deceased donor kidney transplant. So you're waiting in line while you're dialyzing. So that's one reason why you might need a kidney transplant, and the reason why you might need to be on chronic dialysis. And the reason why you might wait longer on the deceased donor waiting list is based on your blood type. So blood type B, for example, has a longer wait. If you've got a lot of antibodies against other people's blood, tissues, organs, you can wait a long time. And obviously, if you don't have a living donor. If you're unable to find a willing transplant center that will transplant you, and it is true that even today there are some transplant centers in the US and around the world that will not transplant someone with C3G. It's unfortunate, but there is this misplaced belief that they are doomed to early recurrence and failure. So there are some centers that won't take you. And you might not have the resources to travel, say, to Iowa City and be considered for a kidney transplant. And then there are patients, appropriately, I think, who want to wait for the right time to be transplanted, because as you heard from Dr. Nestor, we don't really have any established therapies if the disease were to come back. And so you might choose to wait for a better time. And this might be particularly true if you've already been transplanted once and you're unfortunate enough to have lost your first kidney from early recurrent disease. So these are the three situations where chronic dialysis is a very reasonable option. And the first one is a common option for most people, so they don't have a living donor and have to wait. All right, so if you have to do chronic dialysis, the best form of chronic dialysis is hemodialysis done at home, so-called home hemodialysis, where you have a portable machine that you take home and you dialyze yourself for a couple of hours, 5 to 6 times a week. That is the best way to dialyze yourself, because it gives you the best sense of well-being. It manages your fluids better, manages your electrolytes better, and keeps your chemistries in check. And by the way, it appears to have a survival benefit that seems to be almost close to an option for kidney transplant, which is a transplant from a deceased donor. So the whole purpose of getting a kidney transplant is not just to feel better, it's that generally people live long with a kidney transplant. And there's a whole host of other benefits from a kidney transplant. But at least in terms of living, and this is a study now that was published quite a while ago, 2009. This is what is called a survival curve. So at the start of the observation, 100% of people are alive, and with time, people die of a variety of reasons. So this is a 10-year time horizon. And there's two lines here. The one of these lines relates to a small group of patients from many different countries who were on short daily hemodialysis. And their survival is very close to the entire cohort up until that point of patients in the US who had received a deceased donor kidney transplant, and that's up to 2004. And you can see that it matches. So bottom line from this small study done 15 years ago, the survival with home hemodialysis is almost as good as a deceased donor kidney transplant. So something really to consider. Here's another study. So this was done from Virginia, a much more recent study. The difference between the previous study and this one is that this is a cohort from the state of Virginia, from one center where they are closely managing patients who happen to be on this intensive home hemodialysis, another acronym for the same home hemodialysis that I talked about. Now the survival curve, you can see the survival curve is now much better 15 years later. And this is the same, or nearly the same time horizon. Here are deceased donor transplants, here's home dialysis, and here's living donor transplants. So living donor transplants, again, by and large, give you a better survival than deceased donor transplants. All right. What about kidney transplant? That is the preferred option, or the option. How do you get a kidney transplant? Well, first you have to qualify. You have to meet criteria that allows you to be on the deceased donor wait list, or if you have a living donor that the insurance company recognizes as being sufficiently advanced kidney disease that you deserve to be transplanted. So basically, you have to be at least 18 years old and have an eGFR, which is an approximation of your kidney function based on serum creatinine, of something around 20 ml per minute or less. That gets you to the waiting list. But if you're less than 18, we give children an advantage. They just have to want to have a kidney transplant. It doesn't matter what their kidney function is, although most of us respect that rule. But for children, we have some additional considerations. So you have to qualify, you have to want it, and the transplant center must accept you. And that's in principle all you need to get to a kidney transplant waiting list. And then, unless you have a living donor, you wait your turn. All right, so how do you prepare for your transplant if you were to sense that your kidney function was declining to a point where this might be necessary? We want to be thinking about this as early as possible. We want to discuss this with a nephrologist. We want to get him or her to refer you to a kidney transplant center. Not every practicing nephrologist has a transplant center in their backyard or working at a transplant center. You want to take your support person with you, and you want to be prepared for a long visit, because there's a lot of people that you will meet at the transplant center. Some centers take a couple of days to finish it. We try and finish it in 1 day, but you're going to be meeting with a transplant surgeon, a transplant nephrologist, a social worker, a nurse coordinator, a dietitian, a pharmacist, financial counselor, you'll have a whole series of blood tests. We get x-rays. For those who are older, we might get a stress test and an EKG. And sometimes when there are certain other conditions, we need them to see specialists. So if they have this monoclonal gammopathy that is indicative of, say, a possible cancer, they might need to meet an oncologist. If there are psychosocial issues, they may see a clinical psychologist. We may get a CT scan. I've already talked to you about a stress test. So it can be a very long day, but we try to accomplish it all here in one day. So what you want to be thinking about when you're preparing for a transplant is dialysis versus a transplant. We're going to try and get all the tests that you need to get done. Sometimes there are some leftover tests that you'll get at your own place. There are typically vaccinations that we want you to have, and for those of you who consider eculizumab, you know you've gotten some extra vaccinations beyond the standard vaccination set. You want to ask your transplant center, what are you going to do if the disease recurs? You want to get on the transplant list. You want to maintain your hemoglobin around 10 or so. That's optimal, regardless of what disease you have. You want to think about finding living donors, and that's my second talk. And then you would ask those living donors to contact the transplant center. We can't call them cold. They have to make the first approach. And you want to keep your contact information up to date because you might be on a ski trip in Switzerland when you get the call. We need to have a way of contacting. But if you're really going to Switzerland, you need to tell us you're going to be out of the country for a certain period of time so that you're not on the match run temporarily. And that's also true if you have a temporary illness or if you get pregnant or you need surgery that we need time to heal, then we would give you that space and time. So we need to have up-to-date information on your well-being so we know that when we call you in, you're ready to be transplanted. All right, so this is the question that often comes up. Should patients with C3G be transplanted? And our own philosophy is anybody who has not been previously transplanted should absolutely be transplanted. Because that's, as best as we can tell, the best statistically for the vast group of people with C3G. But those that have been transplanted and have had early recurrence may want to think about their options might be. But if they haven't, if they've had 15, 20 years with their C3G, come back for a second transplant because you've had an outcome from that transplant just like anybody else with any other condition. And the risk of recurrent disease can be influenced by a whole host of things. And I know that Dr. Nestor talked to you about steroids, mycophenolate mofetil, and tacrolimus, drugs that are used in patients who haven't yet got to a transplant to prevent or treat their C3G. Those are the standard drugs we're using to prevent rejection in kidney transplantation, and yet recurrence happens. So it tells us that those drugs really are not sufficient to prevent C3G in everyone, but maybe it does in some. And the various things that can influence it are your sex or gender, age, genetics, not just genetics that make you susceptible to C3G that we understand, like the complement pathway, but genetics and other genes that might make you more susceptible to a whole variety of kidney diseases. There are autoantibodies and obviously complement activity. And important thing to consider is that recurrent disease doesn't always lead to premature graft loss. And in C3G, that's particularly true. Because if you go looking for C3G in the transplanted kidney, you will find it as early as day 3 or day 4. But those are not meaningfully clinically relevant disease. And we would like to prevent early kidney loss because it comes with consequences that reverberate beyond that first kidney transplant. First, early failure will predict recurrent early failure, unless there's some new drug on the horizon, or a long time has passed and the disease has become quiescent. Second, if you lose your kidney early, usually that means you will develop antibodies against that kidney, which then portends reactivity against other people in the population who might be kidney donors for you and can make future transplants difficult. So you want your first kidney to be your last kidney and your best kidney, but that's not always possible. All right, so when should people be transplanted? Ideally, when the disease appears inactive, not that we can say for sure who's inactive and who's not, especially if you've got to dialysis now, you've been on dialysis for 5 years or 10 years. How does one know that the disease is inactive? Because the primary organ it affects is already dead, so to speak. So we don't really have a good way to tell, but when you've been quiescent for a long time, you assume the disease is inactive. And if some patients on dialysis make no urine, so we can't really test for red cells or casts in the urine, we can look for signs of complement activation through the MOL lab. We can look at C3 in the plasma, and those can help us determine if the disease is active. But just because it isn't, doesn't mean the disease isn't going to come back. So it's a very imperfect situation. And you've heard that adults greater than 50 and the transplant center greater than 40, we would go looking for a monoclonal process, a process that indicates that a particular blood cell called the plasma cell is proliferating like a cancer and making an abnormal protein that, in addition to being a cancer that can affect various other organ systems, that abnormal protein can sometimes behave like a C3G causing autoantibody and cause C3G. So we would want to treat it, not just to prevent C3G, but also because it's a possible cancer that might progress under the influence of immunosuppression. And that is something I'm going to be mentioning, that immunosuppression can make you more prone to certain cancers. How should C3G patients be transplanted? As with other transplant, living donor is always best. And I was asked to speak to you about some immunosuppressive regimens, specifically the 2 versus 3 drug regimen. So we start the process with something we call an induction antibody. That's a powerful antibody used at the time of transplant. 3 different ones that are currently in use in the United States. That's the generic name, that's the brand name, the trade name. And for maintenance, our standard therapy is tacrolimus, 2 different branded formulations. Now there's a generic formulation, 2 different versions of mycophenolate, mycophenolate or myfortic, with or without prednisone. So this is the 2 or 3 drug combination. And by the way, prednisone used here is very different from prednisone used in native kidney disease, which is very high doses. Even centers that use prednisone kept their prednisone down to 5 milligrams or less by 3 months. And the standard maintenance dose for years then is an extremely low dose of prednisone that doesn't give you many of the side effects that you saw on this. There are many other choices we use because of drug intolerances for a variety of sorts. We have this tacrolimus alternative for cyclosporin, mycophenolate alternative called azathioprine, and then some additional drugs like sirolimus and everolimus. And we have one injectable given once a month called Dialysis or Neurologics. And we have no data to support the preoperative use of eculizumab, but just like the native kidney situation, when we are stuck, we might reach for eculizumab if there's aggressive recurrence. And we need to have a plan for monitoring for recurrence, which is no different from monitoring for disease progression in the native setting, looking for blood in the urine, looking for protein in the urine, looking for change in kidney function. And the side effects of drugs, various infections, and the thing about immunosuppressive drugs that we use in kidney transplant setting, it doesn't make you more prone to the common infections. It makes you prone to very serious, unusual, opportunistic infections from viruses and fungi that don't ordinarily cause disease in us. So many of us, 75% of people my age, have had cytomegalovirus. 75% of us have had Epstein-Barr virus. Most of us don't even know we had it because it passed through us as a common cold or a minor viral infection. But in transplant recipients, those infections can be deadly. In the susceptibility of some cancers, including lymphomas, there's an increased risk of diabetes from the drugs we use, increased risk of kidney disease. So tacrolimus, cyclosporin can cause kidney injury, as Dr. Nestor told you. They have to be very careful monitoring the dose, walking between too little and too less. Otherwise, you might get kidney disease, the very thing you're trying to prevent. It's very side effects, low blood counts, hair loss, by the way, seen with tacrolimus, hair growth is seen with cyclosporin, and depending on your sex, you might prefer to have hair loss. And weight gain is also a problem. All right, so I'm way out of time, but I was also asked to speak about fair exchange. And that's what I'm going to try and very quickly go through this. So there's 2 ways to get a kidney transplant you already heard about: deceased donors versus living donors. And pretty much today, any person can be a living donor. Sibling, your parent, your child, your neighbor, your acquaintance, somebody you haven't even met who sees your social media post, can all be your donors. The only thing that matters is that they have to be healthy, willing to donate, and understand the risks. All right, so you can have a compatible donor, that is a person whose blood type matches yours, and we call that a blood type compatible donor, much more likely to be related than to be unrelated. You could be incompatible, and you could be incompatible either because your blood type doesn't match or because your HLA antigens are antigens to which the recipient, the person who needs the kidney transplant, has antibodies already directed against. Or you may be compatible but not ideal. So a grandparent wants to donate to their child. We might think about finding a more compatible donor, compatible in terms of age, because an 80-year-old might be very healthy, that's still an 80-year-old kidney going into a 50-year. All right, so to learn about transplant outcomes, I have just one slide. C3G is universal by biopsy, so we don't go looking for it. Some centers do something called a protocol biopsy, looking for early disease recurrence. We don't do it, but if we know, we will find it. And clinically meaningful disease, the old data would suggest that 50% by 3 to 5 years, and kidney failure about 50% in 7 to 15 years. The way you can look at that is that 50% are going to do just fine for 15 years. So that's again why I'm telling you that kidney transplant is always the first best option. So here's my summary. It's the preferred option for any patient with end-stage kidney disease from C3G, get all the recommended vaccines. And you have to remember that some vaccines cannot be given under the influence of immunosuppression, those that contain live viral particles. Second, all vaccines are less effective when you're on drugs that suppress your immune system. The whole purpose of vaccines is to make you make antibodies, and our immunosuppressive drugs suppress that. So you want to be vaccinated before you get transplanted. And that's what happened during COVID-19. There was no vaccine for it until you had been transplanted. So there's a large number of patients, unfortunately, who died from severe COVID through no fault of their own. A new disease came on the horizon and they weren't lucky enough to be around to be vaccinated. Or those that did get the vaccination after transplant was completely ineffective. There's no specific treatment yet for C3G. And if your transplant isn't an option, consider home hemo rather than center-based dialysis. All right, questions? And I have another talk, so you can also keep it for the next one.